Thank you for the opportunity to give you my talk about histiocytosis. And I know that you had some case presentation yesterday about from Vienna about a patient who gave the talk about. Yeah, you okay? I'm sorry, I wasn't here, but I was still on a train. But I know your story about the patient that you were successful to get rid of the BRAF clone in peripheral blood using the chemo. So sorry for that, I wasn't present there. I have no conflict of interests. Yeah, okay, except of histiocytosis. Okay, what are the histiocytic disorders? It's a group of very rare diseases characterized by accumulation of aberrant cells that originate in dendritic cells of macrophages, and the clinical course of the disease is also very variable. They can sometimes go to spontaneous remission with sometimes even no treatment, and sometimes they can progress to very intensive disease that needs very intensive care, including the allogeneic bone marrow transplantation. And always there is some risk of late sequelae of the disease. And this is the current classification of histiocytosis. It was published in 2016. And I would like, yeah, here is the mouse. Yes, can you hear it? Yeah. L group, within the L group, there is the LCH, that's the most common, Langerhans histiocytosis, and L-Harchester disease, ECD. And when it was published in 2016, it was believed that this L group is characterized by mutations within the MAP kinase pathway. That's true, but these mutations also occur in other types of histiocytosis. C group is the group of disease of juvenile xanthogranuloma, that is mostly common. R group is the group of the disease of Rosai-Dorfman disease. M group are malignant histiocytosis. They behave like a sarcoma. And H group is hemophagocytic lymphohistiocytosis. It's completely different disease. It's a syndrome. You have to fulfill five out of 9 criteria to have HLH. But it also belongs by definition to histiocytic disorders. But in my further talk, I will focus only on LCH. That is the most common. So, and I will start with 3 case reports. This is the first case report of a neonate with this multiple skin pustules. Otherwise, the kid was okay, no weight loss, no fever, fully breastfeeded. We did a skin biopsy that was done from axilla, from here. And it revealed Langerhans histiocytosis. BRAF mutation was identified. The kid underwent a through completely examination with bone scan and abdominal ultrasound, blood sampling, and everything was okay. The patient was enrolled to LCH for trial to Straton 6, that is the registry for patient that does not need systemic treatment, and this kid did not receive any treatment. No steroids, no topical steroids, no systemic steroids, nothing, and this lesion regressed, and the patient is okay with 6 years of follow-up, with no signs of the disease. This is a different story. It's an 11-year-old boy with multi-system Langerhans histiocytosis that presented as a painless mass on a skull. And we identified with examination the multi-system disease with multifocal bone, lungs, and thymus involvement. His lung involvement, it's not typical for LCH, but it can happen. We did a bone biopsy from the skull. It revealed LCH with this uncommon BIT-C2 BRAF fusion. The patient was also enrolled to LCH for trial, but to Stratum 1, group 1, and he was randomized to be treated with vinblastine and prednisone, one lung here. At the end of treatment, this lesion regressed, but still to some extent, but still persisted. We did the lung biopsy, but no active LCH was at that time identified. 26 months after the end of treatment, new multifocal bone lesions appeared, and there was the progression within the lungs. We changed the treatment according to the study to vincristine, Aracin, and prednisone, and he was randomized to have a maintenance of indomethacin, and the treatment was planned to be given for 2 years. But when he was still on the indomethacin, a new PET-avid lesion appeared in the lungs, or the lesions progressed, and we changed the treatment to trametinib with very good and, let's say, rapid metabolic response. And the patient is treated with trametinib for more than 18 months, and except of skin toxicity, he's doing well. And we are right now trying to wean off of this trametinib, and we will see if the disease will recur or not. And this is another case report of a patient with multisystem increased organ positive LCH. He was diagnosed at 11 months with skin, mucosal, liver, spleen, spleen involvement and diagnosis. Disease activity score was 6. We did a skin biopsy. This is the plaster from the skin biopsy, and it revealed LCH with BRAF mutation, but also we identified the BRAF clone in peripheral blood, in the cells, and also as a free circulating DNA. The patient was again enrolled to SA4 trial, started the prednisone and vinblastine, but at 6 weeks the disease progressed. And that time the patient was extremely ill. He was at the end. He was at the border of multi-organ failure. He was febrile. He was transfusion dependent, and had some signs of renal deficiency and etc. And we started the vemurafenib, and suddenly the patient was healthy. When we commenced the vemurafenib, I've never observed such a rapid clinical response to any treatment like in this patient with risk organ positive LCH. We were able to discharge him in 14 days from a very severe condition. But on vemurafenib, the BRAF clone persisted. And we started the vemurafenib in a small dose. The BRAF clone persisted, so we doubled the dose of vemurafenib. Still, there was the BRAF clone persisted. So we've indicated him for bone marrow transplant, because at our institution it's a long tradition of bone marrow transplant for LCH with good results. But even after bone marrow transplant, the BRAF clone persisted. For some time, after bone marrow transplant, for a short time, we stopped the vemurafenib, but the disease immediately progressed. So we reinitiated the MAP kinase inhibitor, in that time dabrafenib, and but still the clone persisted. For some time, we combined the dabra and trametinib, but still the clone persisted. And due to the toxicity, we had to stop the dabra, and the patient is continuously treated with trametinib, and still the clone persisted. And he's treated with this MAP kinase inhibitors for more than 7 years. So, what's LCH? It's a rare clonal myeloid neoplasia, when in various tissues aberrant dendritic cells that resemble normal skin Langerhans accumulate. It's a rare disease. The incidence is between 4 to 9 cases per 1 million children. It means that in the Czech Republic, we've got a population of 10 million. We've got about 8, maybe 10 new kids with LCH a year. There is a MAP kinase pathway alteration, and as I told you, the clinical course is very variable, from self-limiting disease to rapidly progressive multisystem disease that even might lead to death. And there is always the risk of late sequelae of the disease. The diagnosis always has to be done by histology. Histological tissue analysis is mandatory. On the left, there are the Birbeck granules. That was the gold standard for many years for using the electron microscopy for confirmation of LCH. Nowadays, it's not longer used. We need to see the typical hematoxin and eosin and positivity of CD18 and langerine, CD207 in histological examination. The bones are, LCH can affect any organ except of genitourinary tract and gonads. The bones are most commonly affected. Approximately 80% of patients have bone affected, mostly on a skull vault. Then skin in 25%. Then the risk organs, liver, spleen, and bone marrow. Lungs, also about 6 to 8%. GI, endocrine tissue, whatever. In Prague, we also had a patient with LCH of lungs. And when we look at the age distribution, the multi-system disease and the skin involvement is usually presented in small kids. And as I told you, the hallmark of this disease is hyperphosphorylation of ERK. This is caused by MAP kinase activation. This is the pathway that I think you already know, and the most common alteration is the mutation of BRAF V600. The other most common mutation is the mutation within the MAP2K1 in MEK, and then the other. And here is the hypothesis how it can happen that that just one genetic alteration or one genetic change can cause such a variable presentation of the disease. And this is the hypothesis that when the mutation occurs or activation occurs in tissue-restricted dendritic cells, it leads to low-risk single-system LCH. When it occurs in some so-called circulating precursors or something like that, it goes to low-risk multifocal or multi-system LCH. And when it occurs in hematopoietic stem cell or even in a Yolk sac, the current hypothesis is that this mutation occurs in a Yolk sac of the embryo. And you know the hematopoiesis starts in Yolk sac, then it goes to liver, spleen, and bone marrow. So when the mutation occurs in hematopoietic stem cells or in a Yolk sac, it causes the high-risk multi-system LCH with risk organ involvement. And this is the largest study published recently by the Dutch group, where again the most common alteration is mutation of BRAF V600. The other most common mutation is MAP2K1 mutation, then the exon 12 mutation, and the others. Kids with BRAF mutation are usually older. No, not sorry. Are usually younger than the others. And this chart also focuses on BRAF mutation. And here again, I believe, yeah, it's quite well readable on a large screen. The kids with BRAF mutation are usually younger, have usually multi-system disease, and have more common risk organ involvement than the other alterations within the MAP kinase pathway. And the BRAF mutation can be also found in peripheral blood, usually in high-risk patients with risk organ involvement. This was the first publication by Karel group from Houston, when they identified mostly in high-risk patients this mutation within the peripheral blood cells, and it corresponded. The presence of these cells within the peripheral blood corresponded to the treatment. And there was also the prognostic significance that in those who had the mutation found in peripheral blood cells had a worse prognosis than those that there was a mutation was not present. And it was confirmed by the French group that focused on cell-free DNA as a biomarker. But again, the data are pretty similar. It's usually found in high-risk, risk organ positive LCH. But they also identified some patients with single-system LCH that had a free circulating DNA within the peripheral blood. I also have some of those patients that have single-system LCH, but we can detect the mutation in peripheral blood as a free circulating DNA, and again, it corresponded with the outcome and with the prognosis of the patient. This is the current classification of lung cancer histiocytosis. Nowadays, we classify the disease as a single-system disease when one organ or system is involved or affected. Bone can be unifocal or multifocal, then isolated involvement of skin, lymph node, lungs, CNS, and others, and multi-system disease where two or more organs or systems are involved. And on the right side, here is the definition of risk organs. The hematopoietic involvement occurs when there is the base cytopenia, that means anemia and or leukocytopenia and or thrombocytopenia. The spleen involvement, when there is enlargement on the spleen, and liver involvement, when there is enlargement on the liver and or liver dysfunction, defined as a hypoproteinemia or hypoalbuminemia, or histopathologic findings for sure. Maybe some of you still remember us or still know this historical classification, eosinophilic granuloma. It's one single lesion. Hanschel-Christian syndrome is the syndrome of diabetes insipidus, multifocal bone lesions and exophthalmos, and lateral side disease is the disease of small kids and infants with liver, spleen, and hematopoietic system involvement. And it was famous Sidney Farber that on a meeting of American pathologists, and I think it was in 1947, presented that these three diseases complete a similar histological appearance on a microscopy. And that time the disease was reclassified or renamed to histiocytosis X, when X meant that it's unknown origin. And Christian Nazarov, another famous physician and also one of the founders of the Society, identifying the dendritic cell origin of the histiocytosis, and he also identified the B-break granules using electron microscopy. And that time the disease was renamed to Langerhans histiocytosis. And another milestone was identification of those recurrent or mutually exclusive MAP kinase mutations. And this is the presentation for LCH. Usually the osteolytic bones, usually on a vault of a skull, but can affect almost every bone except of hands and feet. Here you can see that here is one vertebra missing, and when we look at the CT, this is the involvement of rib, but also of a vertebra, and here is another lesion. Sometimes these lesions can be so bizarre, as you can see in this patient at the bottom. Oh, yes, sorry for that. Vertebra plana, another typical presentation of LCH. This is the destruction of a skull base. Historically, this patient would be classified as a Hanschel-Christian, the osteolytic lesion on a skull base that pushes pushes eyes, the lesion, the mass pushes eyes up front, so exophthalmos and diabetes insipidus, because this destroys the neurohypophysis. And this is the skin involvement. Here, this is the patient that I showed you his case report at the very beginning of my talk. This lower abdomen is pretty typical for localization of SLCH. Here can be just a candida or neonatal diaper rash, but this localization is, I would say, the pathognomic of LCH. Also behind the ears and external otitis, sometimes it resembles severe seborrheic dermatitis, but this is also LCH. Sometimes it can appear as a pustules. And lung involvement, interstitial lungs process, and on a CT, multiple cysts and small nodules. These lung involvements usually heals to the scar that it can cause, it can end up as interstitial lung disease and restricted lung disease. And CNS involvement, here is the lack of a bright spot of neurohypophysis, so you do not see the bright spot here, there is something missing. This is the tumor of an infundibulum hypophysis caused by LCH. This patient has developed to have a panhypopituitarism, and this is the neurodegenerative LCH, one of the most severe and most difficult forms of LCH. This is that we usually do not know and don't know how to help these patients. Yeah. So what are the diagnostic evaluations when we have a patient with LCH? In medical history, we ask for pain, swelling, skin rashes, weight loss, loss of appetite, purine rate. We ask for always for polyuria because of the risk of diabetes insipidus, diarrhea, dyspnea, smoke exposure. LCH is accompanied with smoking and social behavior and neurological changes. In physical examination, we focus on rash, jaundice, pallor edema, lymphadenopathy, irion gamma, palatal lesion, dentition, soft tissue swelling, tachydyspnoea, in case of liver dysfunction, of CAST test, liver and spleen size, and neurological symptoms. In baseline evaluation, we assess the blood count, the hemoglobin, and white blood count with differential erythrocyte sedimentation rate that corresponds to the activity of the disease, the blood chemistry. We focuses on liver enzymes, ferritin to rule out the macrophage activating syndrome, coagulation studies with fibrinogen, the screening test for diabetes insipidus, that's early morning osmolality, to see if patient is unable to concentrate his urine. Abdominal ultrasounds, we ask for liver size and structure of liver and spleen, and chest radiograph and skeletal radiograph survey. We do the X-ray of every bone of the body except of hand and feet. Nowadays, the whole body examination, like whole body MRI and PET-CT or PET-MRI, sometimes substitutes this skeletal radiograph survey. There is a publication from Vienna group that used this whole body MRI to assess the patient with LCH. But I would like to stress that it should be interpreted with a caution, because we know that LCH with just one single lesion has a excellent prognosis, and the publication from Vienna group that they upstage 6 patients because of this whole body MRI, and we don't know whether this patient will, and they were treated, and we don't know whether this upstage was really necessary, because LCH can regress also by themselves. And when we found something abnormal in this basic evaluation, we continue with a more specific evaluation. Where there is B or pancytopenia, the bone marrow aspiration should be done. When there is for example, lung involvement, the patient should have the lung CT scan. When there are suspected vertebral lesion, the patient should have the MRI of the spine. When there is some diabetes insipidus or any endocrine abnormality, the patient should have the brain MRI, etc. And this is again the definition of the risk organs: there's a bicytopenia, enlargement of the spleen, and enlargement of the liver, plus the dysfunction of the organ. The French group developed the disease activity score for patients with high-risk disease. And when we go from the bottom of this table, is mostly the transfusion dependency, the albumin transfusion dependency, the elevated of liver enzymes, the enlargement of liver and spleen, fever, and we calculate these points, and it gives us the score of this high-risk disease, and it's used for subsequent evaluations. And when it was published in 2004, it has a strong prognostic influence that nowadays, with the use of inhibitors, is to some point lessened. And Histology Society also developed the criteria of response, when the disease is classified as better, when there is complete resolution of lesions, of regression. Disease is classified as intermediate when the disease is stable, and worse when there is the progression of the LCH lesions. And it's the same for disease activity score, as I showed in the previous slide. How to treat the single system LCH? Wait-and-see strategy is good, mostly for skin involvement, and also there is the recent publication that even one osteolytic lesion or skull wall can be just followed, and it can regress by itself. On the other hand, the surgery, this is usually used for histology and for proper diagnosis. Just a small biopsy is enough to have a diagnosis, and also it starts, or it augments the healing of the lesion. So wait and see surgery is a very good strategy. When the kid has a skin rash, we can use a topical steroid, or steroids can be used with surgery when they use the crystalline methylprednisolone to infiltrate the lesion. It also helps with the healing. And we can also use the systemic therapy when the surgery can outweigh the risk of the given of the chemotherapy, for example, when there's a large lesion on the leg, on a bone that weighs the body. The chemotherapy can be used, vinblastine and steroid, but the chemotherapy can be pretty short, 3 to 6 months. The treatment of multisystem LCH was developed mostly by Histology when in the last 3 studies more than 1,000 patients were enrolled, and the current LCH4 study is still ongoing and recruiting the patients. In the first study from 1991 to 1995, more than 500 patients were registered, and there was the randomization between vinblastine and etoposide. The patient received the bolus of steroids and then were randomized to receive vinblastine and etoposide, and treatment duration was 44 months. And this study proved that vinblastine and steroids are equally effective as a single drugs, but there was a high reactivation rate. This treatment strategy did not provide adequate disease control. And in this first study, it was clear that that patient with liver, lung, spleen, and hematologic system involvement had a particularly poor prognosis. And also the response at week 6 was a strong prognostic factor. The patient did not respond to the treatment at week 6, had a poor prognosis. The second study focused on high-risk patients. They were classified to have these high-risk patients was defined by age less than 2 years, age at diagnosis, or involvement of the risk organs. Again, large number of patients were randomized to receive vinblastine and prednisone, and vinblastine, prednisone, and etoposide. And the first big what we learned is that the age by itself it's not a risk factor. It's only the risk organ presence. That means that the risk that the age below 2 years of age does not bring any prognostic informants. And the other, that treatment duration was pretty low, only 6 months, and it was a very high reactivation rate in this study. And the third study, LCH3 study, the patient was divided to be into 2 groups, high-risk groups with risk organ involvements and low-risk group. And this high-risk group, the patient was treated with first 6 weeks of vinblastine steroids. Those that did not achieve the complete remission continue with another 6 weeks of vinblastine and steroids for the first time, and then with maintenance therapy. And the patient was randomized to receive vinblastine prednisone and vinblastine prednisone methotrexate. And in this study, the addition of methotrexate did not bring any advantage. In low-risk group, the patient was randomized to be with maintenance therapy 6 to 12 months, and the prolongation of maintenance to 12 months reduced the reactivation rate from 54% to 37%. Since that time, the combination of prednisone and vinblastine for 12 months is the standard treatment of multisystem LCH. So this is the frontline treatment of LCH. First induction, 6 weeks of injection of vinblastine plus steroids. Then the patient is assessed at week 7. Those they do not achieve the non-active disease continue with the second induction. Second 6 doses of vinblastine plus steroids is given in boluses, and then the patient continue with the maintenance therapy. The vinblastine given every 3rd weeks, and this is given for 1 year. But there are still the challenges. First is mortality using this treatment strategy. The mortality was unacceptably high in the patient with involvement of the risk organs, 15% mortality. And the second problem was morbidity, and mostly the number of reactivations, that the reactivation rate was still about, or is still about 30 to 40% using this vinblastine steroid treatment. Therefore, there are many second-line therapies that can be used for treatment of LCH. First, repetition of frontline regimen. Second, that can be used in the patient that when there is at least some gap between the first diagnosis and the relapse. This vinblastine, prednisone, and cytosine arabinoside is studied in the LCH4 trial currently, and other strategies like cytosine arbenocyte and low-risk non-NCL, non-CNS LCH, and CNS LCH. This is mostly in the United States. Cladribine for recurrent low-risk LCH, clofarabine for multifocal bone disease, bisphosphonase and indomethacin, and this high-dose RC and cladribine can be used as a salvage therapy for high-risk LCH with risk organs and liver dysfunction. And right now I will focus on MAP kinase inhibitors. This is these are the mutations as I mentioned before, and this pathway can be blocked. The RAF can be blocked using vemurafenib and dabrafenib, MEK using trametinib, cobimetinib, and there is also ERK inhibitors in development. And there is, as I told you at the very beginning, the response to these inhibitors is excellent. On this waterfall plot, you see that the patient uniformly reacts, and in this picture below, it's highlighted how the patient reacts when you start this inhibitor on LCH. But the problem is that when there is still the clone detectable in the peripheral blood, you cannot stop this inhibitor's therapy. If you stop it, the disease invariably recur. And nowadays we are working on a treatment strategy within our eco group to get rid of this patient, because in this recent article by Paul Milner from Newcastle, it's clearly showed that when you just treat patients with the inhibitors, you don't get rid of the clone that is still in peripheral blood. Patient is in clinical remission, but the patient has to be continuously treated with MAP kinase inhibitor because there is still the clone that persists. Chemotherapy can rid of the clone. So nowadays we are developing the exit strategy, how to stop the inhibitors in these patients. And the last slide of late consequences for LCH, mostly the diabetes insipidus can occur in up to 20-25% in patients. The neurological consequences can occur also and pretty late. The most fear is neurodegenerative LCH, and when it affects, for example, the vertebra, patient can have orthopedic complications, panhypothyroidism, growth retardation, etc., etc. So to conclude, lung cancer histiocytosis is rare myeloid neoplasia with constitutive activation. MAP kinase genotyping should always be preferred to monitor the disease activity, also to monitor the treatment response indication of targeted therapy. The frontline treatment is the combination of vinblastine and steroids given for 1 year. Various second-line therapies exist, and that can be used, including MAP kinase inhibitors, and there is always the risk of late sequelae of the LCH. That's it.
Who wants to start with a question?
Thanks, Karel, for the excellent talk. So when I read the first sentence of your slide, what we have learned when we were at medical school, that this is an inflammatory disease, has been skipped completely. So it's a myeloid neoplasia.
It's myeloid neoplasia. Yeah, and we are happy that it's neoplasia because we are pediatric oncologists.
So it will stay in pediatric oncology.
Thank you very much. I have a question for the first patient you showed, the easy one. How long do we wait? So in what time range can we expect that the lesions will disappear? Because that's what the parents will ask me.
Yeah, it's usually within the weeks. Weeks, yeah, usually. And the funny is that I also have one patient that is treated with topical steroids, but have the BRAF clone in a peripheral blood detected. And I just follow this patient for, nowadays I think it's for 8 months. There is still clone, but the patient has only the skin disease. So I would like to stress that the detection of the BRAF clone within the peripheral blood is not as similar as a minimal residual disease in leukemia. It's completely different information. But unfortunately, in histiocytosis, we do not know what's the information nowadays. I believe that we will learn it. No other questions, please?
Well,
Good.
How do you treat neurodegenerative disease?
It's difficult. Yeah. Actually, there is no standard treatment. In Japan and also in France, they have good experience in using high-dose immunoglobulins, IVIG. It helped to some patients. It stabilized the disease. And some patients are treated with IVIG high dose for many years, and they remain stable. Some patients in US, they have a good experience with Rsch monotherapy, that they gave the patient, I think, 5 to 6 cycles of Rsch monotherapy, also with good results. But again, it helped, as in with IVIG, only to 15 to 20% of patients. And nowadays, the MAP kinase inhibitors are studied. And in my experience, yes, it helps. To some extent, it improves the neurological situation or the neurological situation of the patient. But yes, it helps to some extent. The problem is when to start the treatment.
Or when to stop the treatment.
And when to stop, yeah. Right. Nowadays, I know that there are some patients where they try to stop it. And as far as I know, the neurological status goes to be worsened again. So they reinitiated this inhibitor therapy, and then he went to the baseline, the patient. I do not know any story that anyone really stopped it. Maybe there are some, but I do not know it. My patient, I continue with that, and again within the ECHO, the European Consortium of Hysterocytosis, we are planning the first meeting in June that we will focus on this question, and we will try to find a solution because there is currently no solution.
Thank you.
Thank you. Just going back to the neurodegenerative disease, we've got a patient with radiological changes that look like neurodegenerative disease, but no clinical evidence of neurodegeneration.
Yes.
How do you manage that sort of case?
Yeah. You know, first the problem is that we do not know how many patients have this signs of radiological neurodegeneration within the whole cohort of patients of LCH, because there is no one study that will do the MRI of every patient with LCH. Currently, we know that the patients that have high-risk LCH, they should be followed by the MRI because at least approximately more than 50% have these findings then. But the clinical degeneration develop in them between 10 to 15%. Still, we have no clear data in how many of them the clinical degeneration will develop. In my clinical setting, I never treat just the MRI findings. I'm always waiting for some clinical, because you can initiate the inhibitors, why not? But when to stop? And it has its own toxicity. Yeah, good question. Intrathecal treatment? Actually, there was done one autopsy in a patient, and since that one autopsy, we think that the neurodegenerative LCH it's actually the active LCH, it's the active disease from one autopsy. But I do not know that there was ever studied that the intrathecal treatment and the LCH. I don't think so.
Yes, and intrathecals only reach the meninges and not the deeper parts.
Yes, not the deep. Yeah, exactly. It's controversial. It's also controversial in HLH for in hemophagocytic lymphocytosis. It's controversial.
Intrathecals only reach the meninges and not deeper parts of the brain. So,
but it was not studied. Yeah.
I have one more question. There's still some mortality. You've got sometimes these really ill patients presenting. At what point do you initiate new therapies or trying to be innovative?
Definitely.
When do you introduce it?
Nowadays, no one should die of the LCH because we've got inhibitors. In the study that we are planning is the gap between the start of standard treatment with vinblastine, and still, if you have very ill child, half of them with BRAF mutation and everything, more than half of them respond very well and very rapidly to vinblastine prednisone. So from my point of view, the vinblastine prednisone should always be commenced. And within the study that we are planning, the gap to start the inhibitors therapy is 14 days. That means 2 doses of vinblastines. But on the other hand, it will be, you know, at ICU and really, really ill, give inhibitors.
Thank you so much, Karel, for your excellent talk. Are there more questions?
Good.
Final question, of course.
When you see the rash, you know, in the upper part of the diaper region, would you always go ahead and biopsy right away? Because I've seen people have that, and the parents are, oh, we switch the diaper brand, or we put a bit of topical steroids, the GP, and it goes away. Is that okay? Or if you hear that, you're like, oh, you should right away dig deeper?
I love hysterocytosis. I will always go for a biopsy to learn it, because I know that the skin LCH is definitely underdiagnosed. But you know the topical steroids helps a lot usually, and yeah, and even this, if you will know that it's still the skin LCH, it can disappear by itself with no treatment. So yeah, doesn't have to be done, but in any DAPs, you should do it.
And when it's already gone, and parents tell you that,
when it's gone, there is no reason to do a biopsy.
But should you tell the parents that this type of disease exists or not? You just see the photos, it's gone. Should you tell them, or should you just let them live happily without having heard about?
I am a little bit biased. I love LCH, but when it's gone, no.
Thank you.